Hi everyone, this is my presentation on magnesium and hypertension. So magnesium is the body's fourth most abundant mineral and serves as a cofactor for over 300 enzymes. And they play a role in nerve conduction, muscle contraction, regulating heart rhythm, and transporting potassium and calcium ions across the cell membranes. And these all impact body functions that play a role in blood pressure. The RDA is around 400 milligrams per day for adults, but only half of the US population gets adequate magnesium from foods. Magnesium-rich foods range in 30 to 115 milligrams per serving, and some examples of foods that are rich in magnesium are spinach, almonds, lima beans, oat bran, mackerel, and bananas. Toxicity is rare, but can result in slow heart rate, low blood pressure, and coma. For this purpose, I'll be focusing on deficiency or hypomagnesemia, which can result in some complications like arterial calcification, diabetes or diabetic kidney damage, and high blood pressure or hypertension. Hypertension can also be caused by other factors besides magnesium deficiency, and these can vary from person to person, such as genetics, fluid and sodium imbalances, and stress. Here's a chart just going over the different categories of blood pressures. It's measured in millimeters of mercury, and systolic, which is the top number, is the amount of pressure in the arteries during contraction of the heart, and the bottom number, diastolic, is when the heart is between beats. The goals and importance of this study are mainly to find out if if magnesium supplementation can prevent the onset of hypertension, and also if it can help keep blood pressure levels under control. This is important because there are 86 million adults with hypertension, and only half of them have it controlled to a pre-hypertensive state. And even this pre-hypertensive state can still result in increased risk for various cardiovascular issues like vascular disease, myocardial infarction, stroke, and chronic kidney disease. The conventional treatment, which are common medications like diuretics, angiotensin converting enzyme inhibitors, and calcium channel blockers. And I mentioned previously that magnesium has been shown to be a natural calcium channel blocker, so this can potentially be something that would come into play during the study design if someone's taking these medications, and magnesium could have a synergistic effect on blood pressure. And these medications can have side effects like headache, dizziness, muscle cramps, and edema. Whereas magnesium supplementation, it's rare to experience side effects unless someone takes too high of a dose, and that can cause loose stools. So the current literature is inconsistent due to diverse designs and studies using different forms like citrate, oxide, and amino acid chelate. Citrate has been shown to be the best absorbed. So also the dose of magnesium used varies between studies. Many that I saw showing an effect, having a beneficial effect on blood pressure, used doses around 365 to 450 milligrams, whereas other studies that showed no effect were using lower doses, below 200 milligrams, as well as inferior forms. So the subject baseline health status is also important to take into consideration. If they are hypertensive, they may be more likely to respond to the treatment. And also if they're taking blood pressure medications, they could experience a reduction in blood pressure that's not necessarily due to the magnesium supplementation. Also, the way the baseline magnesium levels are assessed, if they even do assess it, the way they look at that varies, whether it be serum, which is the most common, red blood cell, or RBC, and urine. RBC is more accurate to look at magnesium status since only 0.3% of magnesium is stored in the serum. So I'm proposing a new study to clarify the potential magnesium supplementation to prevent hypertension. As I've mentioned, there are various designs in current studies looking at this relationship causing heterogeneous results. And many of the studies and meta-analyses I've looked at they've proposed that future research uses a larger sample size, a longer duration, measures blood pressure as the primary outcome, and uses an experimental design, such as the one that I will be using for this study, which is a randomized double-blind placebo-controlled. Study will consist of 150 men and women ages 30 to 45 years old. And to help eliminate bias for randomizing the subjects, an Excel sheet will be used to determine whether they will go in the placebo or the magnesium group. And I understand the long duration of the study is also a limitation, since it can increase the chance for subjects dropping out due to inconvenience or other factors, and also it increases the risk for uncontrollable factors like weight gain or loss, diet, and stress to impact blood pressure. So the inclusion criteria, they are going to be within the ages of 30 to 45. And I chose this age range because there's an increasing prevalence of hypertension in younger adults. And even if it's just an elevation in blood pressure and they're not in a hypertensive category, that does increase their chance for becoming hypertensive stage 1 or 2 as they get older if they don't control it now. And the sample size was determined by the G-Power program for a two-tailed t-test, and you can see the criteria I used there. I did want to make sure that the groups were the same size, so I used an allocation ratio of 1. And so the faculty at UCF will be the subjects that are included, and they have to reside within 20 miles of campus year-round. There will be flyers placed around campus on bulletin boards in various buildings to recruit people for this study, and they will have the incentive of school bookstore gift card upon study completion. They also need to be normotensive, blood pressure between 120 over 80 and 140 over 90, and have a red blood cell magnesium in range between 4 and 6.4. Subjects will be excluded if they've been diagnosed with hypertension or other heart-related disorder, if they've had a previous cardiovascular event like stroke or myocardial infarction, if they're obese with a BMI over 30, if they're currently taking magnesium supplements or medications that can impact blood pressure. And smokers will also be excluded because it has shown to increase and decrease blood pressure, so I didn't want to let that be a factor that could pose limitation to the study. Also, before the study takes place, they'll be doing an IRB proposal since this study is involving human subjects, and it's not, it cannot be exempt or expedited. And the subjects will read and fill out a consent form that will show the study details and lay out the risks and benefits of participating. This corresponds with the Belmont principles of treating subjects as autonomous individuals, and we're ensuring that we're maximizing their benefits and minimizing the risks, and that every risk and benefit is distributed evenly among all subjects. I don't really see any potential risks for this study, except for if magnesium is not effective at preventing hypertension or keeping blood pressure under control, then the subjects could experience elevations in blood pressure, and then they wouldn't be controlled. But if magnesium is effective, then subjects who would have otherwise developed hypertension might reduce their risk of developing it and its associated complications. And these consent forms will be secured in addition to the subjects being given number identifiers to help ensure confidentiality. So the 150 subjects who met the inclusion criteria will have baseline blood pressure readings, and then they'll be randomized to either the placebo group or to receive 400 milligrams of magnesium citrate. As I mentioned, that's the form that's been shown to be best absorbed, and that dose is within the range of many studies that have shown an effect or a beneficial effect of magnesium on blood pressure. So the blood pressure readings will be taken once a week, every Wednesday, at one of 5 locations around campus. The subjects will be given a reminder every Tuesday to remind them that when they get to work before they eat breakfast, they need to go and have their blood pressure taken. 3 readings will be done, and the average of those 3 will be recorded. And at this time, the subjects will be given a week's worth of their placebo or treatment capsules, and they'll be instructed to take these every day with lunch for consistency. So the study will be quantitatively analyzed. After 12 months, we'll have a lot of data on each subject and within each group. So we'll use descriptive statistics to calculate the mean, median, and mode. And then from there, we'll use a two-tailed t-test to assess the difference between the mean of the blood pressure of the magnesium group compared to the placebo group. And this is the primary method we'll be using to analyze the data. The paired t-test will be done as well, but just for supplemental information, comparing pre- and post-treatment blood pressures within each group. And this could particularly be helpful if the two-tailed t-test shows a statistically significant difference between the 2 groups. So what do we expect? So we've eliminated factors that could affect results. For example, healthy subjects taking no medications that affect blood pressure and the long duration. For shorter studies, acute elevations in blood pressure due to outside factors like stress from traffic or work, getting to the reading site, can have an impact on the overall results. So having this long duration, like this study has, can help to even out the effect of these acute elevations. Also, in addition to what has been shown in other strongly designed studies, I expect that this study will show magnesium group to have lower blood pressure than the placebo group, and the magnesium group to show a decrease or less of an increase in blood pressure when compared to the placebo group. And if p is less than 0.05 for these differences, we can then reject the null hypothesis and conclude that magnesium supplementation has a beneficial effect on blood pressure. I did want to mention that for the careful design, using the higher absorbable form and the dose that's been shown to be effective helps to decrease type 2 error or the false negative result. So what is the significance of this research? If we discover that magnesium supplementation has the potential to prevent the onset and to help manage hypertension, we can increase the percent of population that has their hypertension under control. And one of the outcomes of this is that we can help to get ourselves to meet the Healthy People 2020 goals. We can decrease the risks of the prevalence of life-threatening cardiovascular issues associated with elevated blood pressure. And also, one of the most important things, I believe, is setting the groundwork for future studies to see where else magnesium's effect on blood pressure could be beneficial. For example, during pregnancy, the elevation in blood pressure is called preeclampsia, which it's very dangerous for both the mother and the baby. So if magnesium is effective at lowering blood pressure, studies could be done looking at its use during pregnancy to reduce this risk of preeclampsia. And here are all of my references, and I appreciate you taking your time to listen to me. Have a great rest of the weekend.